there is objective science that says that chocolate is a vegetable, okay? So, no day without chocolate. Yesterday on the airport, I made a little promotion video in a chocolate store on the airport. And if you follow me on social media, then at the beginning of next year, you're going to see that airport film. Okay, let's have a look at the functional examination. So, everything starts with inspection. What do you see? And you can see the obvious things, of course. It's red, it's blue, it's black, it's swollen. Yeah. There is some atrophy. There are some deformations. The traditional things. But for me, inspection starts when the patient is sitting in the waiting room. I go to the patient, welcome, please come in. How does he sit in the waiting room? How does he stand up? How does he walk? And how does he sit at my desk? Okay, for a shoulder patient it's not so important, but for a spine patient that could be very useful. How is the patient undressing? In my setting, I don't have a separate space behind the curtain where a patient is undressing, and I don't have this. I'm sitting there. Okay, we did the history, and the patient is undressing there. And with one eye, I see what's happening. If the patient tells me that he has a lot of problems with flexion, I have to see that when he takes off his trousers. Yeah? And specifically when they don't have the impression that you look at them, then you see interesting things. Yeah? Yeah? But already at the end of the treatment, it's also important. Because we give some, for spine patients, we give some prophylactic measures. I give him some exercise. And I give him some advice. Okay, the first days, try to avoid that kind of movement or do it more in this way. Traditional prophylactic stuff. What's the first thing you see when a patient is dressing again? They sit and they put on their shoes. I just explain them to them that in the next days, perhaps they can do that in a different way. They understand that, but immediately, they do it in a wrong way. If they do it behind the curtain, you don't see that. The patient, you cannot react, and the patient doesn't realize it. And then I immediately say, hey, hello, what are you doing? Let's try to do it in a different way. Yeah? Perhaps next days you can try to do it like this. Yeah, but I cannot put my foot on your chair. That's true. That's why I have this little black chair. This is the foot chair. Yeah? Okay. little details, but also important details which determine the success of your treatment in the long term. Okay, good. What's the purpose of our examination? You would like to know which structure is responsible for the complaints. And you would like to know where. And sometimes we are lucky. Sometimes we find in the examination what we call a localizing sign. Let me give you one example. We do a resisted maximal isometrical contraction abduction. On which muscles do you put stress? Tell me. Supraspinatus, also deltoideus. Yeah. Let's imagine, later on in the examination, you find a painful arc. No pain, no pain. Ow, 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 ow. Ah, now it's better again. What is a painful arc? A painful arc, something between humerus and acromion is temporarily squeezed in. Yeah? Could it be deltoid? No, because he lies on top of it. So in combination with resisted abduction, probably it's supraspinatus. Which part of supraspinatus? The tenoperiosteal part. So the painful arc tells me that it is supraspinatus tenoperiosteal. I don't have to palpate anymore. Tomorrow, I give you 5 reasons for a painful arc in the shoulder. This certainly is an exam question. Okay, come back tomorrow. Another example, resisted elbow flexion, painful. Resisted supination, painful. You think of which structure? Biceps. But imagine there's also painful passive pronation. Well, there's a rare biceps lesion on the insertion on the radial tuberosity, and during a pronation, this could be also squeezed in. And when this is inflamed, then the patient is going to say, ha, ha. Localizing sign. Okay. I told you we don't perform too many tests, as less tests as possible. But we have to make sure you perform your tests in a correct way. May I invite you on stage? Thank you. Voilà. You're going to notice that orthopedic medicine Syriacs is also romantic. But you already know that, but you don't know that, but that's how I got married. Yeah, my wife is also physio, and she's a Brazilian physio, and I was teaching in Brazil, and she was sitting at the first row on the left corner, and yeah, apparently I was always watching in this direction, and yeah, this is the result. Already 24 years. Okay. I want to do a passive lateral rotation. I go to the end of the movement, and then I slightly provoke and test the end feel. I feel an elastic end feel, but I did a mistake. Because it's not the end feel of her shoulder I feel, it's the end feel of my Belgian beer. She's much more mobile. Make sure you go to the real end. And why this romantic position? Because I don't want her to compensate too much. Okay? It might look like a silly detail, but it's super important because some lesions only provoke end range pain. If we don't go in range, you don't find it. Yeah? Okay. I want that she's doing a lateral rotation against resistance. Okay. But you know what most of the patients are doing? They're doing this, huh? Yeah, but this is more supraspinatus. This is more infraspinatus. So, say to the patient, keep your elbow against the body. I block it, and I show to the patient, I don't want this, I want that. Okay? Voila. Okay, thanks. Yeah? Those little details are important because if we don't perform our test in an optimal way, our result is also going to be what I call wishy-washy, not very reliable. Okay? And on all the courses I teach, I always see the same. When we exercise the examination techniques, most of the colleagues are pretty fast satisfied. We do it once, we do it twice, and then we sit and we go back to the smartphone. Okay. That's your choice. It's not the best choice. Use the time you have here. Do the examination 10 times. With this small group, this is the ideal setting to do a lot of partner change. You're going to do the techniques on different people. Yeah? So, a lot of partner change today and tomorrow. Don't worry, you can't get pregnant, okay? Although, we already welcomed several CX babies. That's true. Good. So it's really important your examination technique is super. Good. Also here, ask neutral questions. When we do a test, what is the number one question we ask to our patient? All of us. What is the question we mostly ask? You do a test and you ask to the patient. What do you feel? Mm-hmm. Yeah. Yes. Yes. Does it hurt? Yeah. That's not a good question. And you know why? Let's imagine I am your patient. I have pain at rest. I'm standing here. I don't do anything. My shoulder hurts. You do a test with me. Does it hurt? I'm honest. Yes. You think positive test. But I have the same pain. I have the same pain as I have at rest. But I don't know the difference. You ask me, does it hurt? Yeah, it hurts. Huh? So never ask, does it hurt? Instead, as you say, does it change anything? Yeah? Perhaps patient can have more pain. He can have less pain. It doesn't change. And if the patient has pain, always ask where. Let's imagine you have a patient with pain over here and you ask him to do an extension. Does that change anything? It hurts. Where? Don't automatically assume it's here. Huh? Then the patient says, ha ha ha, it hurts here or it hurts there. So extension is going to cause a peripheralization. Clinically, it's important. Huh? Yeah. Okay, so when you do 10 tests, 10 times you're going to ask, does it change? Yeah? Good. And then we performed our tests. We have the package of positive and negative tests. How do we interpret that? Well, something typical celiacs. We're going to make a distinction between two groups of structures. Do they have a contractile problem and or an inert problem? What is contractile? Muscle belly, musculotendinous junction, tendon, insertion. That's the contractile group. What is the inert group? All the rest. Ligament, bursa, disc, menisc, nerve, fascia, whatever. So this is my main question. At the end of the examination, what did we see? A contractile lesion and or inert lesion. Okay?
Why was the fascia in the inert?
Yeah, because some people don't agree with that. Some people put it rather in the contractile group. That's why I put it, but I believe it belongs in the inert group. Yeah, yeah. That's why I did it. Yeah. Mm. Okay, what else do we have? Ah, yeah. What I mentioned before. Do we really test what we think we are testing? Uh-huh. Remember, there is still a $1 million award for those who can, in a relevant way, who can interpret the mobility in the sacroiliac joint. Huh? Let me tell you a very old story. The story is from 1972. Very old story. Conference, manual therapy. It was on the Canary Islands. Of course, I was not there. I was 7 years old at that moment. My father was there. And some big names in the manual therapy world, Kaltenborn and some others. Yeah. And Dr. Meunier is a French doctor, osteopath, who is really well known because of his very good research. And he presented a patient on this conference, and he asked to a number of manual therapists, examine my patient. And come to a conclusion. What may you expect? If 10 highly qualified therapists examine the same patients, you expect that more or less they come to a similar conclusion. Yeah? What was the result? 10 different opinions. And the problem with those therapists is, and with therapists in general, the magical words, I feel it. Because some therapists discovered a hypermobility in the sacroiliac joint in that direction and a hypo in that direction and a hyper there and all possible variations they discovered because they feel it.
Veľa nálezov objavili len na základe toho, že to cítili.
Are those therapists idiots? No. But they use a non-relevant tool.
Avšak využívali také nerelevantné nástroje na vyšetrenie.
If you go with your car to the maintenance and the mechanic man needs the key number 5 to open your engine, but by coincidence he has a key number 7, it's not going to work, huh?
Ak ideme napríklad do servisu s autom a má mechanik iný kľúč k dispozícii, tak
This-
to s tým neotvorí.
This is the disease in manual therapy.
Je to priamo
Useless,
manuálne.
useless keys.
Tak máme častokrát aj
Okay.
také nezmyselné kľúče.
But you know what the best part is of the story? Dr. Menier showed the x-ray of the patient.
Pokračovania toho príbehu tej konferencie.
And what could they see on the x-ray? The lady had a congenital fusion of the SI joints. The lady didn't have any SI joints, but the manual therapist detected, I feel it, a hypermobility. Yes.
Spravili tejto pacientke na tej konferencii rentgen a vlastne mala kongenitálne spojenie toho SI klbu, čiže tam nebola ani pohyblivosť absolútne
That's-
možná.
That's 50 years ago. Has been multiplied several times. There's research about that. And they are still teaching today this bullshit.
Toto sa stalo ešte pred 50
Yeah?
rokmi, ale napriek tomu sa to stále ešte vyučuje.
And that's a moment where I become a little bit more arrogant and a little bit less diplomatic. Eh? Forgive me for that. But I don't get it. I don't understand it. Eh? Okay, so what is important? You're familiar with this terminology, the sensitivity of the test and the specificity of the test. And then this is expressed in the kappa factor. The kappa factor,
Takisto aj senzitivita toho testu,
Just-
špecifika toho testu a táto terminológia.
just to give you an idea, sacroiliac mobility tests have a kappa factor of 0.1, 0.2.
Špecificita tohto testu pri tom SI
In-
je
in-
0,1 až 0,5%.
In some studies, they even have a negative factor. So my question is, why the hell should you do that?
Čiže prečo by sme tento
Huh?
test
Huh?
mali vôbec používať?
Okay, good. So keep it simple. We're going to use active test, we're going to use passive test, we're going to use resisted test.
Spravíme si aktívne testy, pasívne testy
But
a rezistované.
I'm talking about the extremities. The spine is a different world.
Teraz
Okay.
hovoríme vlastne o končatinách, pretože to je úplne iná kategória.
We don't use too many active tests.
Nepoužívame príliš veľa aktívnych testov.
For instance, hey, flex your elbow. Ow. Who cares? Where is the ow coming from? From a contractile problem or from an inert problem? I don't know.
Teraz sa pýtame na to, či ten problém vychádza z tej kontraktilnej
Because during
pohyblivej.
an active test, both contractile and inert structures are in action. I can't differentiate.
Obidve štruktúry sú vlastne v pohybe, nevieme to nejako diferencovať. v tej
The only active test in the complete extremities is this one. Okay, and this one.
pri končatinách. Aktívnej pohyblivosti sú tieto pohyby.
For other purposes. So we're going to focus on passive test and resisted test.
Preto sa viac zameriavame na pasívne testy a rezistované testy.
Passive tests are mainly tests for the integrity of inert structures,
Pasívne testy sú
Mainly.
zamerané hlavne na hlavne zisťovanie tých nepohyblivých štruktúr.
and resisted tests are mainly tests for the contractile structures.
A odporové testy sú zamerané hlavne na vyšetrenie kontraktilných častí.
Mainly. Of course, with a passive stretch, you can stretch contractile tissues.
Ale takisto s pasívnym stretchingom môžeme natiahnuť aj kontraktilné
And
štruktúry.
during a resisted test,
A
you
pri
can-
odporových testoch
you can also compress inert structures.
môžeme takisto vyvolať kompresiu pohyblivých častí.
I give you a nice example. Resisted elbow extension, maximal isometrical contraction. Does that change anything? Yeah, it hurts. Where does it hurt? Oh, here. Huh? You do an extension and you get pain at the biceps. That's not logical.
Čiže môžeme mať aj v takomto prípade bolesť pri extenzii v oblasti bicepsu.
But
Nie je úplne logické však.
if the patient has a subdeltoid bursitis,
Ak má pacient subdeltoidnú
during extension, you could get more pressure in that direction.
tak pri extenzii môže mať tlak týmto
And
smerom.
depending where the irritation is in the bursa, C5 structure can cause C5 pain.
A závisí, v ktorej oblasti sa nachádza tá burzitíza, ale môže byť v tom celom dermatóme C5, vtedy prítomná tá bolestivosť a prejavy.
More about that later today. Yeah? Okay. What exactly are we testing? Pain, range of motion, and end feel.
Testujeme bolestivosť, rozsah pohyblivosti a konečnosť.
And with resisted test, pain and weakness.
A pri rezistovanom testovaní
Those,
a slabosť.
those are the variables which are always in my mind. And of course, with passive tests, we test the end feel.
Pri pasívnych testoch testujeme koncový pocit.
So when I did the lateral rotation on you, you are young, you are mobile. That's very elastic. If you do that on an arthrotic patient, that's going to be harder.
Pri mladých pacientoch môže byť ten koncový pocit prirodzene elastický, pri artrotických pacientoch sa tak môže, avšak môže
If,
byť
if you do that on a traumatic arthritis patient, an acute arthritis, it's going to be muscle spasm.
reumatoidnej artritíde to môže byť až taký svalový spazmus.
So what is interesting me is the end feel normal or not normal?
Čiže ten koncový pohyb normálny alebo nie je normálny.
And in the not normal, mostly it's too hard or muscle spasm, one of the two.
Môžeme nad tým, či tam je konečný tvrdý pocit alebo svalový spazmus.
Okay. Well, the moral of the story is look at the things that matter and don't look at the things that don't matter. I gave you the example before, how the scapula is a little bit more like this and this pelvis is a little bit more like that. That's not so important. And I have a little film that illustrates that.
Záverom je, že sme sa pozerali hlavne na štruktúry, ktoré súvisia s tým a nie na tie, ktoré nedávajú zmysel
But
v tom kontexte.
the film is not related with orthopedic medicine. Oops. Sorry. Sound. Where's the sound? The sound. Yeah. Thank you.
Ha mangiato il cecchino, eh?
No,
Senta, mi sa dire che ore sono adesso?
allora. 7 quarti.
Ma sono le 7:15 spaccate, incredibile! Ma lei come fa? A leggere l'ora nelle palle del cecchino, scusi?
No, io le alzo. Sto cercando di 7 quarti.
So, ladies, when you come home tonight and you ask your husband what time it is, my kind of humor gets more crazy and crazy. Too much serious. Okay, so we're going to try to use a standardized protocol.
Budeme sa snažiť využiť štandardizovaný
And
protokol.
for each joint, we developed the standardized assessment form where you find all the details of the inspection, the history, examination.
Každý klub máme taký štandardizovaný protokol, kde nájdeme vlastne tie
This weekend we're not going to work with that, we're going to work with that on another occasion.
ale tento víkend s tým nebudeme teraz pracovať.
But for instance, a basic shoulder examination, just 12 tests.
Základné vyšetrenie ramena obsahuje len 12 testov.
Yeah. We see the tests over here. We have the different variables.
Máme tu rôzne premedné.
For instance, for passive tests, we interpret pain, range of motion, and infield.
Pre pasívne testy interpretujeme bolesť, rozsah pohybu, koncový pocit.
For a resisted test, we interpret pain and weakness.
Pre odporové testy interpretujeme bolesť a slabosť.
Just a basic protocol. But you're going to be surprised this afternoon how much information we can get from just 12 shoulder tests.
Budeme prekvapení, koľko informácií dokážeme dostať len z 12